So as I mentioned right at the beginning, we're going to start out by hearing from a group of people who have different involvements in the Moonshot and the Cancer Challenge. And it's my pleasure to start out this process by introducing to you Jules Samada, who's an assistant professor of medicine at the University of Utah. And his focus is on genetic epidemiology and inherited cancers. And Jules is really an absolute star here at Huntsman Cancer Institute. He's done remarkable work. He's already widely published. And I'm actually going to ask Jules to step up and introduce the first of our prospective speakers this afternoon. Jules. That's now on. Okay.
Great, thank you so much, John, and wonderful to be here. So the first speaker I want to introduce is Greg Johnson. Greg is a textiles artist who's really trying to outlive his family's history of cancer. To do that, he undergoes a colonoscopy every year where upwards of hundreds of polyps are removed from his bowel to prevent these developing into colorectal cancer. Why is this so important for him? It's because of his family history. He lost his mom at a young age when she was just 47 to colorectal cancer. Looking at his family history, his mother's mom, meaning his grandma, also died from colorectal at 42, just like many other people in the branches of his family tree. He keeps his health in check with annual colonoscopy, with seeing the doctors at Huntsman Cancer Institute and the University of Utah regularly. His family's also been investigated or interacted with the research program at Huntsman for the last 20 years, and really tests from that family confirmed what was already probably apparent to them, that their biological lineage included a genetic mutation that predisposed them to colon cancer. Importantly, it can actually be traced back to ancestors that migrated or immigrated from England here in the 1600s. At this point, I'd like to invite Greg to come up to the podium and share his perspectives on the Cancer Moonshot with us.
Thank you, Dr. Samada. When I approached him a little while ago, I wasn't sure if he'd recognize me because usually he sees me from the other side. However, he did, much to his credit. I also think, considering the part of the anatomy that our family is associated with here, that the Moonshot is a great title for this program. Having been involved over past, 34, 35 years, really before Huntsman Cancer Institute was Huntsman Cancer. It was apparent that there was something going on in our family with regards to colon cancer. I had an aunt and an uncle before my mom was diagnosed that went through the removal of their colons. I have been fortunate in the respect that I still have my colon, and it's in large part, thank you, to Huntsman Cancer and all that we have learned. And it's been exciting in a gratifying way to be involved in this program for so many years. I've kept my colon, and I will tell you, I will keep it as long as I can. I do. I have polyps removed every year, up as Dr. Samada mentioned, upwards of hundreds of polyps, and I still have hundreds of polyps. But because what I have learned over the years and what we know, my comfort level in having a colonoscopy every year is that we can continue to keep an eye on it. My family gene is an attenuated version of this familial polyposis, which means it's not quite as deadly. It's still a concern, but if we keep an eye on it, we can. I can continue to keep my colon, which quite honestly I'm attached to, and I don't feel at this point that I'm taking a risk, an unknown risk. I realize that at some point I may have to have my colon removed. It may just become unmanageable. You're looking at part of my family tree, a product of the Utah Family Project. And I think what's really amazing, and I guess I can, well, you'll see me on this little arrow right here. I have 2 sons, one of which has been diagnosed, or which has been, diagnosed with this genetic mutation. We knew that we had a 50% chance, I had a 50% chance of passing this on to my children, and that's exactly what has happened. But my son, at a much younger age than I was, knows that he has this mutation and knows that he too needs to keep an eye on it. I think what's really evident here is that my mother's generation, you can see how many have died of colon cancer by the black diamonds. And with the knowledge that we have through genetic testing now and through genealogy, that next generation, my generation, there's hardly anything there. As far as deaths, we have 1 death and a number of known cases that have this gene. And I would be hopeful that my children's generation, we see no deaths because of the knowledge that we have through programs here at Huntsman Cancer. I've outlived my mother now by 15 years, and I'm hoping it's another 15 years. Beyond that, it's been, again, very gratifying from a patient standpoint to be involved with this. I don't consider myself a survivor, a cancer survivor, because I haven't had cancer. I heard a term the day that Vice President Biden was here that I think very much applies to me. I'm a previvor, and it's thanks in large part to my participation here at Huntsman. And I'm, again, grateful and gratified to be, even as a lab rat, a part of the knowledge and what's taking place here. We have such a great institution here in our midst, and I think that's really something to take advantage of, and it's a great opportunity to spread the message here out to what Dr. Sweetenham said is a kind of a frontier here in the West. So I'm grateful for the opportunity to speak, to talk to you a little bit about my view as a patient, and I will leave it to those that are coming. Back to you probably, Doctor. Okay, thank you so much.
So thank you so much, Greg, for that wonderful discussion. So as a physician, I always have slides. That's how I talk about anything. So do you want me to talk just for a few minutes about the physician perspective? So as a physician who treats, diagnoses patients with gastrointestinal cancers, these are some of the things that I thought, as clinicians or as physicians, we hope the Cancer Moonshot will have a component of. So early diagnosis through screening, whether that's blood, stool, saliva, or imaging, to try and detect cancers at an early stage where treatments can work the very best. The treatments that we do give, can we target them more precisely to the cancer to make them both more efficacious so they work better, but also harm normal tissue less frequently? Obviously, many cancers, if they are found at higher stages, you need to look at palliation and symptom management. bereavement for the patient, and importantly, for their spouse or loved ones that are taking care of them. And then the last area is the one I'm going to talk about in the next few slides, something that Mary and others here have coined as precision prevention, meaning patients who have the highest risk of developing cancer, people who have genetic causes of cancer, can we somehow intervene very early in their lives to prevent the formation of cancer completely? So this is just a diagram showing the various causes of colorectal cancer. FAP, the one at the bottom, stands for familial adenomatous polyposis. This is a rare genetic condition, the one that Greg has and runs in his family. It only accounts for 1% of all colorectal cancer. But you can see here in this slide, the purple bar, these people have a nearly 100% risk of developing colon cancer by the time they're 35 years old, unless they have some type of intervention. You can see at the very right-hand side, the average risk individual, me or you, have a 6 to 10% risk of colorectal cancer. So you can see just how much more elevated that is in FAP. FAP really has its roots in Utah and at Huntsman, going back to the first description of this disease by Eldon Gardner and Randy Burt, and then later on to the genetic discovery of the actual gene, APC, that caused FAP. This is Randy Burt and Ray White, who are both at Huntsman as well. The two pictures are from a colonoscopy that shows all of the precancerous polyps that grow in the colon, and really the only treatment up to now has been taking the colon out surgically. And you can see on the right-hand side, when the colon does come out and it's spread out, you can see the thousands of polyps that occur. However, even after the colon's removed in these patients, they have a risk of a lot of other cancers developing. Most importantly, they can form polyps or these precancerous growths in their small bowel or duodenum, which is the part of the bowel just after the stomach, and that can be as high as 15 to 20% risk. Up to now, we've had no real option to treat those cancers, as once you've lost your colon, you really don't want to lose any other vital organs. As Greg said, most people are quite well associated with their colons and other pieces of their anatomy. So this has led to the notion of chemoprevention. Can we use a medication that can prevent cancer altogether? So there were early studies, these are the bar graphs in yellow here, that showed drugs such as Celebrex, which is an anti-arthritic drug that many people use, or Sulindac, which is a related drug, can decrease the growth of these precancerous polyps in the colon by about a third, 30%. It doesn't seem to work so well in the small bowel. It's only 4% in the second bar. This really led to a need for a better precision prevention therapy for these patients. And I was happy to be involved in the trial with Randy Burt and many other investigators here. Based on studies here, we looked at a combination of two drugs, erlotinib and Sulindac, but you can see just how extraordinarily more successful that medication was, that it essentially caused 70% of the polyps in these patients to regress or disappear after only 6 months of treatment. And looking at any of the other studies that have been done in the 1990s or early 2000s, this has really been hailed as possibly a breakthrough in cancer prevention or chemoprevention. And this is just a photo to show the polyps. You can't see it very well in the lighting, but all the polyps in the left-hand side after 6 months disappeared and was recently published in a medical journal called JAMA. So this really leads to, I think we have hopefully an opportunity for early diagnosis, targeted treatments, palliation, symptom management, bereavement, and hopefully precision cancer prevention in those at greatest risk. Thanks.
Joel, thanks so much. We are very fortunate and very proud of the fact that at Huntsman Cancer Institute that we have three folks here who've been very closely involved with the Moonshot and with the Blue Ribbon panel. Mary Beckley, our Cancer Center Director, is a member of the panel. And we have two members of Moonshot working groups who are also members of the Huntsman Cancer Institute. And Martin McMahon is one of those. Martin is a highly renowned investigator in melanoma, lung, and thyroid cancers, who's the Senior Director for Preclinical translation here at Huntsman Cancer Institute, and a great recruit for us a little bit less than a year ago now from UCSF. So Martin really has the inside knowledge on some of the workings of the moonshot, and is going to talk to us a little bit about that. Thanks, Martin.
Everyone hear me okay? I want to turn the clock back briefly to the early 1970s, when our nation first dedicated itself to thinking about the cancer problem. I see a lot of young faces in the audience, so many of you will not remember the fact that in the 1970s, no one really knew what caused cancer, where cancer came from, how it ran in families. And a cancer diagnosis was often a matter of shame, and embarrassment in a family. And I can speak with personal experience. My older sister died at the age of 6 of leukemia. And my parents could never really understand why that was the case. In the 1970s, inspired by Mary Lasker and many others, President Nixon announced the war on cancer. This war, which I think was his equivalent to President Kennedy's moonshot to land a man on the moon, was thought to be able to cure cancer within 10 years. Now, obviously that has not been successful in terms of eradicating the morbidity and mortality of cancer. But we came from a period of knowing almost nothing about cancer to having the most exquisite understanding of how cancer forms, how cancer risk can be communicated from one family to the next. And the overwhelming message of these many years of study is that cancer is a disease of the genes. Broken genes that in some cases we inherit from our parents, or genes that get broken by accidents of normal DNA replication or repair, or possibly in response to environmental carcinogens or lifestyle factors such as smoking. So we've gone from an era where we were trying to solve a three-dimensional jigsaw puzzle with no pieces of the puzzle in front of us to the genome era, where effectively we've had a series of three-dimensional jigsaw puzzles dumped in front of us on a table. And now our challenge is to solve those puzzles. I gave a lecture about a month or so ago in which I emphasized the fact that even as recently as 10 years ago, diseases like breast cancer or lung cancer were thought of as being monolithic, that a breast cancer in one woman was sufficiently similar to a breast cancer in another woman that a one-size-fits-all type of chemotherapy solution would work. And what we now understand is that breast cancer is maybe comprised of 6 individual different diseases, each of which has their own specific personalized and precision medication approach. The same is true for lung cancer, and an emerging picture is similar for many other types of relatively common cancer. So I think we have reached an era where we have incredible optimism and incredible prospects for future interventions to prevent and treat cancers. But none of this occurs in the absence of a substantial investment in the biomedical infrastructure that allows bright ideas in the research laboratory to be realized and converted into translational ideas that end up being tested by our medical oncologists, surgeons, pathologists, radiologists, and the whole clinical team that participate and engage in trying to prevent and cure cancer. Now, many of you, again, if I turn the clock back now to the early 1990s, will remember that President Clinton doubled the NIH budget over the course of about 8 years. The NIH budget, if I remember correctly, went from around $15 billion to around $30 billion a year. And that led, again, to a remarkable flowering of the biomedical sciences enterprise, leading to even further inventions and discoveries. In fact, one particular discovery that I will highlight for you is the basic understanding of how the immune system can be manipulated to give rise to immunotherapies that now are making incredible advances in terms of our ability to treat certain types of cancer. Now, my little preamble here comes with the following concern, which was that after President Clinton left office, the biomedical sciences budget stagnated and has done so now for about 16 years. Many of us back in 2008 remember our future president, President Obama, promising that he would double the NIH budget over the period of 2008 to 2020. Unfortunately, he didn't specify when the doubling would start. And so if he's going to live up to that promise, I think we have great expectations of what the next few years might bring. But of course, a number of economic issues have sort of intervened and so have not necessarily led him to have the facilities and the finances available to double the NIH budget. But I think one of the reasons why our community of cancer researchers and physicians is so excited about the moonshot is it's coming with a sign of a rededication of our national government to the idea that investment in biomedical research, whether it's in cancer or cardiovascular disease or in other areas, is an important and essential element of what we do well in this country and what we can then use those funds to alleviate suffering in our society. It's coming from Vice President Biden, who has obviously a very close personal connection to the trauma of a cancer diagnosis in the family. And I believe it comes with a firm commitment that the moonshot is the beginning of a rededication of our national effort to try and conquer this disease. Now, Mary had asked me to say a few words about what it's like to serve on one of the blue ribbon panels, and I can demonstrate to you exactly what it's like. I spent many hours on the telephone, but nonetheless engaged in discussions that were led by two very senior members of our cancer research community, Levi Garraway at Harvard and Chi Dang at Johns Hopkins University, trying to discuss and prioritize the area of tumor progression and tumor evolution. Because one of the things that we've come to understand in enormous depth is that cancer is incredibly complex. Not only is each and every cancer from one individual to the next somewhat different, but even within a single cancer, within a single patient, there is remarkable heterogeneity. And that heterogeneity is what gives rise to treatment failures and to drug resistance and to other manifestations such as metastatic spread. And with the powers of genome sequencing and many of the other now very sophisticated tools that we can bring to bear, indeed one of, I don't know if Ben, oh there he is right there, Ben Spike, one of our new recruits from the Salk Institute, one can now take a single cancer cell and profile it by sequencing its entire genome, or to read out all the instructions that are being expressed in that cell at any given time. So we have a remarkable level of sophisticated analysis, and the question now is, how do we bring this to bear for understanding the mechanics of a cancer in an individual patient, of understanding the mechanics of a cancer across an entire cohort, of whether it's colon cancer or lung cancer patients, and how do we invest this money in ways that will break down barriers between researchers and research institutions so that the information that we generate is shared and more rapidly accessible and available to the research community. So I offer you a message of enormous hope that we're on the cusp of something very special in translating our knowledge into effective therapies. And I also say that with the investment that appears to be coming from the federal government, for whom there is no other replacement, I think we have an opportunity to deliver on that hope. So thanks very much.
Thanks, Martin. Thanks, Martin. On the theme of the federal government, it's my pleasure next to introduce Kim Gillan, who serves as Regional Director for the U.S. Department of Health and Human Services in an area that almost completely overlaps with our catchment area out here in the Western Intermountain West. And she's been involved in the role that she has in advocating for laws and policies to help folks fight cancer, and delighted that she's here. And Kim, thank you very much.
Thank you. Thank you very much. It's great to be here, and it's great to see so many people that have come here today to, I want to say, not only start a discussion, but probably in many ways continue the discussion. I would be remiss if I didn't thank the Huntsman Cancer Institute and particularly Ashley for her yeoman's effort to put together this session today. I want to say in a short amount of time, and the epitome of my job with continuing diverse instructions from the federal government. And I say that as a federal employee. One of the things that's really exciting about this is that 6 months ago, President Obama, in a State of the Union address, anointed Vice President Biden to take on this initiative of the Cancer Moonshot. And some of the cynics may say, well, that'll get going in around 2 years. But actually now it is 6 months later, and today Huntsman is joined with over 270 other groups that are here to begin this discussion. And when I thought about what kind of perspective I could bring, is that this is a very different approach that the federal government certainly has a very important role in research, but also in this particular initiative, it's not what I hope is top-down. It's not a regulatory initiative. Instead, we are using our powers to convene and bring together people to continue the discussion, which includes giving some input to the federal government as to where research and investment priorities should be. So I think that that's very different than some of the other health initiatives that everyone in this room may have been involved with. And I also think it is going to be more powerful. So I don't want to repeat what we all know about the Cancer Moonshot, but one, it's all about collaboration. And this collaboration is not just the researchers in one room and the clinicians in another, but it's bringing together the philanthropic groups, the patients, groups that normally don't convene at the same table. And I think that is really, really important, the collaboration. And we in the federal government are notorious for our silos. And so as part of that, part of the Moonshot initiative is to begin to look at what are the institutional barriers that we have in the government. And we've seen a couple of very exciting things, which is starting with some changes with the FDA, the whole emphasis on collaboration and sharing of data, of which the federal government has quite a bit. Also the start of $195 million in new cancer research and activities at the NIH. There is a proposal for the fiscal year 2017 budget for a fairly significant increase in the government's investment in RD at FDA and NIH. And then both the Department of Defense and the VA are being encouraged to establish Center for Excellence with regard to cancer research and cancer treatment. So, a lot of discussion, but where does the rubber meet the road? And the exciting thing is that today, the Center for Medicaid Services or Studies or Services announced that something called the CMS Oncology Care Model. It's an innovative multi-payer model focused on providing higher quality, more coordinated oncology care. And under this OCM model, over 200 physician groups across the United States have entered into payment arrangements that include financial and performance accountability for episodes of care surrounding chemotherapy administration to cancer patients. And I think the reason that is exciting is that we're not just talking about it, and we all know in today's concern about healthcare costs that we have to link the payment reform up with actually the delivery of care. The exciting news is that when they made the announcements that the Utah, and now I'm forgetting the name and I'm embarrassed, the Utah cancer specialists here in Salt Lake are going to be part of that 200 physician group. And so they will be participating for the next couple of years, and which is also good for continuity. So I want to end my conversation today with really, often there's a joke, and since I came to this position from Montana, so I'm very familiar with our Rocky Mountain independent spirits. People say to me, don't ever go to a meeting and say, I'm here from the federal government, how can I help you? I'm not going to do that, and I have never done that in my career, but I want to change it. I'm here from the federal government, and I want you to help us make better decisions about cancer research, cancer investments, and all of the healthcare things. So I will leave you with that challenge, because today is really the start of a journey that's going to take lots of bright minds like are in the room, and lots of time, and of course lots of resources. But I'm confident, since I came from Montana where it's the get her done attitude, that if there's any place that can get it done, it'll be in this region. So thank you very much for attending today.
Thank you very much, Kim. To round out and finish up this session, I want to introduce in sequence two people who are here representing advocacy and community groups. The first of them is Brooke Carlisle she's the Utah Government Relations Director for the American Cancer Society Cancer Action Network here, and has a really very important role within the American Cancer Society in advocating for the cancer patient. The second of them is Sarah Carbajal-Salisbury, who represents the community. I'm blocking exactly on the name, and I apologize, Sarah. It's the Community Alliance. Thank you. I'm blocking on that for a moment. I should know, because she and I have also worked together within the context of UCAN over the last year. But they both represent different aspects of advocacy, patient advocacy, and community organizations. So I'm going to ask Brooke and then Sarah to come up and speak. Thank you.
Thanks so much, Dr. Sweetenham. I'm Brooke Carlisle. I'm the Government Relations Director for the American Cancer Society Cancer Action Network, or ACS-CAN. Rolls off the tongue a little bit easier. So thank you so much for having us. So I'm just going to share a couple of thoughts on the moonshot from both of our organizations, and just tell you a little bit about what each organization does and kind of where we fit into the larger picture. Probably not telling you anything you don't know when I tell you that 2 million people will be diagnosed with cancer this year across the world, and each of them will be relying on research to treat their cancer. Effective research is why we now have 15.5 million cancer survivors living in the United States. It's also why we're saving 500 more lives from cancer a day than we were in 1991. So past federal investment has put the scientific community on the verge of groundbreaking new discoveries that could accelerate our progress. But we all know that innovation definitely requires investment. So it is with this in mind that the American Cancer Society announced yesterday that they'll be doubling their investment in research by the year 2021. We'll increase our annual research investment to approximately $240 million by this year. Currently, we spend about $100 million on research. Those grants go to academic institutions as well as other ACS grantees across the country. So very excited about that. This increase will dramatically grow what is already the largest and, we would argue, most successful nonprofit research program in the country. As an organization, ACS has invested $4.5 billion in research since 1946 and funded 47 Nobel Prize winners. So just a little bit about the American Cancer Society for those of you who don't know what we do in addition to research. We get calls from about 800,000 people a year who want information about cancer, health insurance, clinical trials, matching service, just need a compassionate somebody to talk to at 3 o'clock in the morning, 24-hour-a-day service. We provide rides to people who wouldn't have any other way to get to their cancer treatment. Actually, we have a van that travels from our facility up to Huntsman every 90 minutes, taking patients to treatment. I would be remiss if I did not touch on our Hope Lodge that opened 9 months ago in downtown Salt Lake City, that provides a free place to stay for cancer patients who are traveling to Salt Lake City from Utah or anywhere else and don't have another place to stay. They can stay for as long as they need to. So kind of switching gears to the American Cancer Society Cancer Action Network, ACS-CAN side of the house where I work. We are an advocacy organization So we have worked tirelessly since ACS CAN was created about 11 years ago to increase the budget for NIH and NCI. Have called on Congress for a $6 billion increase. As you heard earlier, we're not quite there yet. But as an organization, we're right there with President Biden and hoping to see that increased federal investment in research. And then obviously ACS is doubling their investment in research. So again, thank you so much. And kudos to President Biden. And we're happy to be a part of the event today and look forward to working with all of you as we move forward.
Thanks, Dick.
Okay, hello, ladies and gentlemen. I'm here on behalf of Alliance Community Services.
Thank you.
There it is. Thank you, Dr. Sweetenham. And I am the program director and one of the founders of the breast cancer programs in our organization. And just to go straight to the point, what it matters for the Moonshot effort, that's the reason we're here. We started the first support group for Latina women with breast cancer back in 2002. And one interesting fact, just last week, we registered the patient number 400 in a database. We've been doing this for quite a few years, but unfortunately we see that the number of Hispanic ladies with breast cancer has been increasing a lot. Just can tell you, just the last couple months, I registered about 15 Hispanic ladies with cancer, most of them with breast cancer. Out of the 400 individuals that we have in our database as survivors, I would say 85 to 90% are breast cancer, and the others represent other type of cancers here in Utah. Over the last 14 years serving survivors, also we have joined efforts with the education program and referrals for screening, early detection program. And in Alliance, up to date, we can say that we're able to serve the Hispanic community throughout the continuum of care for breast cancer. That goes from education, referrals to screening, and support for those that are diagnosed with breast cancer. So this is what we do, and some ideas, some suggestions on how we can collaborate. I appreciated the statement that the previous speaker, no Brooke, but Kim Gillen said to extend collaborations with nonprofit organizations, with community-based organizations. We recently have done a study through UCAN, Utah Cancer Action Network grant, where we were assessing needs. We did a needs assessment of patient navigation services for breast cancer survivors in Latina women. And it was very interesting. I would need much more time to tell you what were some of those findings, but it was very interesting to find what were those needs assessments throughout the different cancer centers in the Wasatch Front. We didn't do the whole state, just the Wasatch Front, and we were able to find out a lot of gaps in the healthcare system to serve those individuals. And currently, we're doing a study with the University of Utah with Dr. Sanchez Beerhead, where we're going to be able to also find needs assessment for metastatic breast cancer Latina survivors. And as we were doing this work, we looked up in the Utah Cancer Registry for what was the percentage of Latina women with breast cancer, and it was reported for, I believe it was 2013 to 2015, or 2014 and 15, and it was between this period of time, they reported 3 Latina with metastatic breast cancer survivor. Just as a support group, the last 12 months, I have registered, well, not registered because some of them is cancer that came back, about 10 Latinas with breast cancer, just the last year. And so I think one of those barriers that are happening also is the data that is being that is being reported, I think is minimizing the what is happening with cancer among the Hispanic population, especially with, in my case that I've done studies and worked with the Latina breast cancer survivors. All those 14 years also have allowed us to, have given us the opportunity to develop different skills to serve the community. So now we're not considering ourselves educators, facilitators of a support group, or community health workers. We believe we have moved up to become patient navigators, where we serve our Latina women in the different gaps that are between the health system and their healthcare. Currently, we have a really strong collaboration with the Utah Department of Health and the Intermountain. And just to give you an idea of how those collaborations have helped not just the individuals, but also the healthcare system, is the Utah Cancer Control Program has reported that the screening of mammographies have gone from 2010 about below 50% to 2015, close to 66% of screening mammograms with the Latina women, just in the valley, just in the Salt Lake Valley. And again, collaborations, we have the experience, we have done this for so many years, we know what are those gaps, what are those barriers that are happening with the Latina women, especially with breast cancer. We'll be happy to collaborate with the research programs that can help our communities. And again, being able to accumulate data, I think will be a great thing to move on with research. And thank you very much for your time.
Thank you. Thanks. So thanks so much to everybody. I think the message for the next 40 minutes or so is we have 40 minutes. And so I think this is going to be a real exercise in collaboration and efficiency to get through this, but I'm sure we will, and looking forward to the next couple of panel discussions. And the first of our panel discussions around access is going to be led by Donna Branson, who is the Director of Patient and Public Education here at Huntsman Cancer Institute, who's had a very, I won't say very long, that sounds kind of bad, doesn't it? But she's had an extremely productive and effective career. Currently is the chair of the Cancer Patient Education Network, and also, again, someone I've had the good fortune to work with not only here at Huntsman, but also through the Utah Cancer Action Network. So Donna is going to moderate our first panel discussion, and Donna, it's over to you.
Come up. Thank you. I'm going to speed moderate. So, well, welcome everybody. It's an honor to be here today to moderate this panel on enhancing patient access to cancer research and care. So like most of the people in this room and those watching us on Facebook, we are streaming this session. I'm excited about that. I dream of a day when cancer will be a thing of the past. And I've seen great progress made in the fight against cancer, but it never seems big enough or broad enough. So the Moonshot is exciting just to see, what we can do with increased cancer research and through increased cancer collaboration. And I'm excited to share some of the work we're doing at Huntsman that's going to help improve patient access, especially in our rural and frontier communities. So let me introduce our panelists. Our first panelist is Jessica Maley. And Jessica has over 10 years of clinical research experience and currently serves as the Associate Director of Operations for the Clinical Trials Office. And Jessica supports Huntsman Cancer Institute's strategic clinical research initiatives while directing the department's 109 staff members that work in various roles to execute HCI's robust clinical trial portfolio. Our second presenter is Jennifer Morales. Jennifer is a community health educator in our Community Outreach and Prevention Education program at Huntsman Cancer Institute. Her position is part of the NIH-NCI National Outreach Network and seeks to strengthen the ability of HCI to develop and disseminate culturally appropriate, evidence-based cancer information that is tailored to the specific needs of underserved communities. And our third presenter is Marjan Champagne. And Marjan is a board-certified and licensed genetic counselor who currently serves as a clinical lead genetic counselor and works closely with the Genetic Counseling Shared Resource Director and their team to address both clinical research needs related to cancer risk assessment, genetic testing, and communication of genetic information to patients and their families. Please join me in welcoming our panelists. And so I'd like to start with each one of them just giving us a brief update about what they currently are working on.
So I'll go ahead and start. In the clinical trials arena, as has been discussed already this morning, that we are uniquely positioned as a cancer institution geographically, and our catchment area is one that is very unique in the United States. With that brings many patients from far and wide, and they come here a lot of times seeking clinical trials to treat their cancer. And we are very, very lucky to have a robust clinical trials program that offers novel, unique immunotherapies and groundbreaking first-in-man studies through our portfolios. We have recently, as a cancer institution, been able to affiliate with more community clinics in our region. Carson City, Nevada, Grand Junction, Colorado, Sweetwater, Wyoming, and Rexburg, Idaho are the list of community centers that we have been working with very closely to lend our expertise and organizational capabilities in order to try to navigate getting clinical trials available to more patients in these areas so they can access the unique components of the Huntsman Cancer Institute closer to home.
Great, thank you.
Hi, I would just like to extend appreciation for being invited to this panel. So as a community health educator with the Community Outreach and Prevention Program, I have been working on a community health needs assessment. And this assessment is tailoring prevention education to rural communities. The goal of this NCI-funded project is to address cancer health disparities through expanded community outreach to our rural catchment area. The CHE project is focused in Tooele, Tri-County, Central, Southeastern, and San Juan health districts, areas in the state with identified health disparities. Just to give you just some context, as a state, colorectal cancer screening rates have closely resembled national screening rates and shown improvement, risen from 48% in 2000 to 71% in 2014. However, Utahns living in frontier areas have lower rates of colorectal cancer screening. The rates of mammography in Utah are 64.5%, and Pap screening are currently lower compared to the rest of the national rate. So it is clear that there is a lot of geographic variation in cancer risk, incidence, and mortality. People who live in rural areas often face challenges to healthcare access, including long distances to facilities and limited transportation options. In some rural areas, we also see high rates of tobacco use, lower screening rates, and lower health literacy. In our rural catchment area, we see higher rates of cancer mortality in at least 2 cancer sites, high smoking rates, and lower cancer screening rates compared to the Utah average. We know the importance of helping the population make informed health choices. In regards to cancer, an informed public can make better decisions about preventative health behaviors and understand guidelines for cancer screenings. Routine cancer screenings are the best way to detect cancer early and increase a person's chances for survival. The Community Health Needs Assessment has been implemented across the health districts, asking community members about their general health and cancer concerns. The needs assessment is a tool to evaluate the assets already present within communities and as well as needs that are yet to be served. The assessment has consisted of surveys, stakeholder interviews, and community focus groups. The assessment will guide our efforts in understanding how to create tailored and innovative ways to disseminate health information. For example, we have successfully used Facebook as a recruitment tool to recruit participants into our research study. We have found that participants are really open to the idea of using Facebook for accurate health information and other social media as well. One of the goals of the Moonshot is to do the work of 10 years in 5. Community outreach must move just as fast in getting health information out to the public. Thank you.
So Marjan.
Good afternoon. I'd like to share with you a little bit about our genetic counseling team at Huntsman Cancer Institute, and just start by letting you know that, our clinical team provides services here at Huntsman Cancer Institute. Those services include genetic counseling, coordination of testing, interpretation of results, and personalized management of recommendations. But we're also a shared resource. And so part of that, our role in that, is to provide investigators who are interested and motivated and enthusiastic about studying our high-risk populations, working with them on those research projects. So, we continue to really bring research and clinical efforts together in order to really enhance patient access to genetic services throughout the Intermountain West. And I'd like to take a few brief moments to share with you some of our key initiatives. In 2007, we began a systematic project to streamline delivery of genetic access to patients who are at risk for a hereditary form of colon and endometrial cancer syndrome called Lynch syndrome. Okay. Over 700 colon and endometrial cancers surgically treated through our center have been screened for Lynch syndrome through this program. And genetic counselors at Huntsman Cancer Institute really direct that initiative. So we review all of the results, we interpret the results, and then we actively engage with patients and families who are at high risk of these genetic syndromes. Those families are at most risk in order to ensure that they're getting appropriate care. In this way, what we've done is we've worked to effectively streamline and increase access to genetic care to those families who are coming through our center and are at the highest risk for these genetic syndromes. A second key initiative was the Family Care Project. Our genetic counselors received motivational interviewing technique training and also practiced counseling, evidence-based counseling interventions to motivate high-risk populations to undergo colonoscopy. And these were individuals who previously were non-adherent to these recommendations. Using this theory-based intervention, we were successful in motivating this population to undergo colonoscopy for the uptake of an increase in uptake of 30%. What we found also is that those residing in rural areas and those lower income families still benefited from this intervention at the same level as those urban residents. And finally, one of our more recent projects was through the REACH project, where we compared telephone and in-person genetic counseling services for women at risk for hereditary breast and ovarian cancer syndrome. In one of the largest comparative studies in this country, we demonstrated that telephone and in-person counseling really were associated with equivalent psychosocial and satisfaction outcomes. And we also found that this arm, the telephone counseling, was really the more cost-effective way to reach out to our rural populations. So then we directly used this research and translated it into clinical care. We now offer telephone cancer genetic counseling services in our partnerships with some of our neighboring states. So we have these services right now in Wyoming and Idaho, and are looking to expand these services further in the next several years. This initiative has really provided increased access, more locally, more convenient for the residents in our region. So there really is this growing need for access of genetic services across our region. And one of our greatest challenges will be to strategically address this demand. And at Huntsman Cancer Institute, we really are poised to address this challenge. We're actively conducting research to identify the best ways to bridge the gap, and then we're using this research information, translating it directly into clinical initiatives.
Great, thank you. We were going to open up to the audience, but I think we'll save that till the last half hour. So do I have time to, I'm going to ask each of you just a question and then just a brief response. So Jessica, could you start by letting us know how you're deciding which clinical trials to open in the community, clinics and hospitals?
Sure. We've formed some strategic working groups that bring together all aspects of clinical trial conduct, specimen processing, pharmacy, imaging and radiology, as well as the coordination resources that are needed and data components. So we look at the regulatory and financial aspects of getting trials activated and determine which are best suited to go into these community clinics. And commonly, we are seeing that those that are more streamlined and limited to the NCTN funding mechanisms that we have, which are national clinical trial networks funded out of the National Cancer Institute, are appropriate for these centers to execute appropriately. We're also assisting them with hiring appropriate trained personnel and providing our onboarding processes for those folks to be able to conduct compliant clinical research. The NIH has pushed an initiative to have a single institutional review board review for human subject research protections, which I think will streamline the activation process and break down the barriers that we see the Moonshot proponents kind of pushing for more collaboration, and this will significantly increase activation to bring clinical trials and research to patients much more quickly.
Great, thank you. Thank you. And Jen, can you tell us a little bit about what is the importance of education in cancer prevention?
I think like what has been mentioned before, when we have an educated public, they're much more apt to make decisions that are key in preventing or lowering or minimizing their risk in cancer, in getting cancer. And so smoking cessation is a large initiative that we work on through this grant. I think that it's also important to have the population have accurate access to education. And so through our Cancer Learning Center, we actively let our population know that that's a service that we at Huntsman Cancer Institute have for the population. I think it's important to have information for our public.
Okay, thank you. And Marshawn, as we work to increase access to genetic services, what are some opportunities for future research?
There are always lots of opportunities.
Briefly.
I think one of the areas where we could really work on is when we do a lot of remote counseling, trying to see how that transitions if these patients are actually receiving long-term care and follow-up. One of the issues with one of the findings for our REACH study was that the patients who received telephone counseling were less likely to receive long-term follow-up care. And so I would like to piggyback, Jennifer, when you mentioned education is really important. We firmly believe that, and so it raises the question of, what are some of these barriers that these high-risk patients know what they're supposed to be doing, they go back to their community centers and aren't seeking out this care, so how can we help them? And so one of the areas that we're working on now is educating our community providers. We've partnered with the Utah Department of Health. We currently offer a bi-monthly cancer genetics echo in which we're providing our genetics expertise to community providers, but there's still, of course, a lot of work that still needs to be done.
Great. Okay. Well, thank you, and we will have time at the end to ask further questions. So,
great.
Thank you all.
Thanks to all of you. I'm sorry we actually have to sort of keep these relatively short, but I have a feeling that the Vice President probably won't wait for us if we run over. So we'll keep going. And the second of our panel discussions is around big data initiatives. And it's my pleasure to introduce Rachel Hess, who is going to moderate this session. Rachel is the Chief of the Division of Health System Innovation and Research and a Professor of Population Health Sciences at the university here, and she has a spectacular and specific expertise around issues of health service delivery, how we improve the service that we provide to our patients, how we measure their outcomes more effectively, and so on. And so it's a pleasure to have Rachel with us. So thanks, Rachel.
Thank you. This is really a great pleasure to have been asked to do this, and we'll hopefully stay on time. I brought timers and notes So I have the pleasure of introducing three people that I am just so excited to know and have in the University of Utah community. Samir Kordi, the Chief Research Information Officer at the Huntsman Cancer Institute and the Director of Research Informatics and Shared Resources. Samir brings his diverse background in computer science and software engineering to oversee all aspects of software development for clinical, translational, basic, and population science research at Huntsman Cancer Institute. His responsibilities include the development of research databases, applications, and collaboration with biomedical informatics core development. And in collaboration with biomedical informatics, the core develops tools and algorithms to support principal investigators. Under Samir's guidance, his team has delivered an integrated software suite comprised of genomic, translational, clinical, and population science applications. Samir's role at the Institute covers research IT, strategic planning, budgeting, project management, analysis, system design, architecture, staff management, resource assignment, and establishing collaborative relationships with HCI and health sciences departments, as well as collaborations with peer cancer institutions. It's unclear to me when he sleeps. Michaela Larson is the program manager for the new research initiative, Huntsman Cancer Institute, Total Cancer Care. She serves as the key liaison for HCI. Do you guys come up at this point? Great.
Yeah.
We'll just come up like kind of, yeah, I wasn't 100% sure on how that worked. Okay. Michaela Larson is the program manager for the new research initiative, Huntsman Cancer Institute, Total Cancer Care. She serves as the key liaison for HCI and the Oncology Research Information Exchange Network, or RIAN, which is just a very exciting program. She is responsible for planning, budgeting, implementing, and communications with this new initiative, and has worked in oncology clinical research at HCI and MGH for the past 7 years, and she's a certified clinical research professional. And John Sweetenham, who needs practically no introduction, is the professor of medicine at the University of Utah and senior director of clinical affairs at Huntsman Cancer Institute. Dr. Sweetenham is a practicing hematologist whose central clinical research interest is in lymphoma. He is internationally renowned for his clinical research and has authored more than 200 original articles, chapters, and books in this area of investigation. He has been the principal investigator on national and international trials in lymphoma and is a former core committee member of the ECOG and national principal investigator for studies in Hodgkin's lymphoma. He has also served as the chair of the Clinical Trials Committee of Leukemia and Lymphoma Research, UK from 2007 to 2014. And most near and dear to my heart, Dr. Sweetenham and his team at HCI are working on the integration of patient-reported outcomes, meaning feedback that comes directly from the patients that can provide useful outcomes data on quality of life and the treatment efficacy. We have about 18 minutes in advance of the Vice President's speech. I was asked to say a couple of things, and then I will turn it over to the panel, and we may have time for a question, or I have a couple if nobody else does. So I really was very excited to be asked to do this. I think the Cancer Moonshot catalyzes our effort in treatment as well as in prevention, and that data sources such as those in the UPDB that we have at Huntsman and at the University of Utah really combine environmental, sociocultural, and genetic data, as well as patient-reported outcome data, to provide us the opportunity to explore the drivers of cancer and to intervene to reduce the incidence of cancer through aggressive prevention and even before positive screening happens, with the new word that I learned today, creating our previvors, which are very exciting. The volume of data necessary, though, is really large, and there aren't many organizations, institutions, or states that have what Utah has to be able to contribute to this moonshot and help us move this forward. So with that, I turn it over to Samir and for his statements, and then we'll see where we are for questions.
Thanks, Rachel, and it's very nice to meet you finally. I know we've spoken on the phone many times, but now in person. I'm going to speak about big data and what it means to the patients. But I figured that first I would start by defining what big data means, because a lot of people use that term now loosely, and I think defining what it means to the general public and even people in science and at the university use that term loosely, but now the term was coined somewhere around 2010, and one man was given the credit of coining that term. And what it refers to is the vast amounts of data that is collected and leads to insights into one subject area. And that subject area now, that data has to be modeled in different ways than the conventional means that we used to model data with. So now we have to use more complex algorithms, more complex modeling techniques to model that data, traverse it, and provide the analysis tools to gain insights into it. And big data includes imaging data, textual data, voice and sound data, and any type of data that you can think of can be included in that sense. Next-gen sequencing data, which is impactful on disease treatments, especially in cancer, and data from social networks like Twitter and Facebook is also considered as big data, and there are many techniques to analyze that data and drive and influence people's behavior by connecting them to the right resources through social networks. And of course, the electronic medical records, which include a vast amount of textual information that includes pathology reports, radiology reports, and clinical notes. So to that end, we have on top of that the vast amounts of data that's being generated by human beings on a daily basis through mobile devices, mobile apps, Fitbits, and the like. Those mobile devices and these technologies can be brought to bear to influence human behavior and lifestyle changes to improve the connection with the human beings so that you can influence what they eat and that they exercise. You're always prodding them to exercise. You see people now trying to say, I've done my 10,000 steps today, only 5,000 left. So that's because of their Fitbit, or that app they have on their iPhone. So we are now at an inflection point with medicine and population health and influencing population health management into better lifestyles, better diet, and then bringing all those things together to influence the behavior of populations, reducing mortality rates from disease, because now we've lowered the cost on the health system and actually targeted the individuals to be more proactive about their lifestyle and their health. And that's a very important thing, especially in this country, because you see a lot of these ads that target the individuals constantly. And with that, we are at a point where we have many opportunities through targeting these areas with big data where we can identify sources of hotspots of disease areas before they become a major problem. We can control outbreaks such as the flu by more information made available to us. And then it also includes many challenges. These challenges include security, privacy, protection of information, and the way we have to mitigate those risks is by controlling access, ensuring individual privacy, and then making sure that the data is encrypted in transit or at rest, and then making sure that we have business associates agreements between vendors of these cloud providers or people that house data off-site, as well as the covered entities. And with that, I'm going to just jump really quick to the Utah Population Database because I feel that's a very important resource that we have here at the University of Utah and the Huntsman Cancer Institute, by which many of you know that many discoveries, genetic discoveries, have been made through this resource. And I had the pleasure to meet Mr. Johnson here and know that his family was instrumental in that APC gene discovery. And we have made many discoveries at this institution that have impacted human health and behavior through environmental studies and population studies. And combining these data points together from the multiple sources, as well as what we have here as a research community, the data that's being generated by next-gen sequencing and the EMR, the electronic medical record, we can guide the individual to lead a better lifestyle and improve disease management and prevention. Thanks.
Thanks, Samir. Well, I'm pleased today to share a little bit about the network that Huntsman Cancer Institute has recently joined. So it's the Oncology Research Information Exchange Network, also known as ORION. This is a collaboration of cancer centers that is growing and currently includes 14 leading cancer centers across the nation who have all agreed to use a common research protocol called Total Cancer Care. And the reason that they've agreed to do this is in order to share data and to accelerate cancer research and findings. This is an outstanding opportunity for Huntsman Cancer Institute to both contribute and have access to a much larger set of data than would otherwise be possible. We had some very exciting news today. The Huntsman Cancer Institute Total Cancer Care research study was approved by the local institutional review board, and we are pleased to begin the process of implementation and offering this to patients that are coming to the hospital this very week. So experience has shown that generally patients are very willing to share samples and data in order to advance cancer research. And we believe that participation in the network with other cancer centers will allow those samples and that data to have an even greater impact. Additionally, the network aims to help match patients to relevant clinical trials, and we're excited about that expanded access in partnership with other cancer centers. We expect this collaboration to be particularly valuable for rare or specific subtypes of common cancers where one cancer center alone may not have many individuals with a particular type of cancer, which can make it challenging to study. But when cancer centers work together and share data amongst each other, the information and data becomes more powerful, and we can find answers to research questions at a quicker pace, and ultimately this improves care for our patients. So I'm really excited to get this research initiative going.
Thanks, Michaela. Me too. I'm going to make just one or two very brief comments. A couple of what I think are important patient care aspects and where the Moonshot really gives us real opportunities. And then one thing, just to be a little bit provocative, is I think a potential challenge and something that we need to recognize in these big data opportunities. You know, one of the big emphases in cancer care right now, from prevention right through the whole kind of cancer journey, is this aspect of value. Not cost, but value. So, you know, the best definition I've heard is Warren Buffett's: cost is what you pay, value is what you get. And what you get is really, when we think about this, what our patients get. So we have our own perceptions about what's important to patients who are being treated for, or maybe in a cancer prevention program, and what we think are the important outcomes. But what we're learning more and more, and Rachel is really a national and international leader in this area, is that patients have very different perceptions about what they want and expect from their care and from their cancer care. And as we develop models for cancer care with improved value, we improve the quality of those models, we reduce the cost, which we have to do because, you know, this is a really expensive business and we have to try to get the costs down to make it affordable. That incorporating into that whole value model what our patients perceive to be important to them is crucial, and it's really difficult. And thanks to Rachel and a number of other people here at the university, we've spent a lot of effort and time into starting to incorporate the outcomes that our patients report to us into our electronic medical record. It's really tough, really important, I think, for the Moonshot to recognize how important that component of care is. And the second thing from a big data perspective is that what we hope will happen is that for someone like myself as a physician, when I'm with the patient, these big data projects are going to inform us about what decisions to make in the way that we manage our patients right there in the room when we're there. We'll have an enormous body of data from potentially millions of people that we can rely on as a resource to direct us into what's the best way to treat our patients. And we're going to need this because none of us can really keep up with the speed at which progress in cancer care and our understanding of this disease is moving ahead. And so the idea that an oncologist, sitting in let me say Rexburg, Idaho, would be in a position where he or she could keep on top of all that without help, it's just not going to happen. So these big data tools are going to be really important. The challenge for us, I think, is that in big data, it's one of those places where size matters, right? In general, not entirely true, the bigger the better, but what we're starting to see already emerging from the moonshot, certainly in the popular oncology press, as I'll call it, is many different groups who are already kind of telling us that they've got their big data program going, and there are X number of big data programs and various ones all across the country. We have Orion, CancerLink, there are many more. I think one of the messages that perhaps needs to be sent back to those who are leading the moonshot is, if we can, let's try not to let that happen. Let's actually try eventually to have one big data set rather than 15 big data sets, because obviously the power of combining all of that is much, much more than just the additive kind of power of those. So I really hope that one of the messages that we're able to send back is, look, let's really work hard to integrate these data sets so that we have one big data set that's going to serve us for the future.
I think that given our time constraints, I have the prerogative to ask one or maybe two questions. And John, I just want to throw out to you, you talked a little bit about getting these data into the clinician's hands and into the patient's hands. And that's really right, like that's the essence. And what resources do we need to really move the big data learning into the clinical system so that we're not on the 7 to 14-year plan, but we're really going from discovery to treatment?
Yeah, it's a great question. I mean, I think that a lot of the resources that we need, to my mind, are really around, I guess I would classify it as kind of IT expertise. I'm just trying to think of a specific example, because so much of the time, actually, really, we already have those data. We just can't access them as well as we should. So one example, I can easily see how, if we had really good data from our patients about, let's just say, their experience of chemotherapy side effects, let's just say nausea as a side effect of the chemotherapy, if we had really robust real-time data from our patients about that, I think I can see very quickly with the right IT infrastructure how we could really quickly, with these big data sets, look at that group of patients, look at other factors in their history, in socioeconomic factors, all of those kind of things, and they would coalesce into a tool that would tell us which patients were most likely to suffer from a particular side effect, not just based on molecular biology, but on all kinds of other factors, and identify for us the patients where we might want to be a little more intensive or think a little differently about how we try to control that. So to some extent, I think a lot of what we need is resources in terms of more robust IT support than we have right now. I think a lot of those data are there. We just need to have better ways to access them.
So Samira, as our IT person, in 1 minute or less, how do you bring the knowledge to the clinician and really make those resources, those IT resources, work with the team instead of sometimes the team feels that they work against the team?
Well, I think John and I work closely together as a team, and we have many efforts going on right now to solve many problems, but solving that nausea problem in the reported text is usually where it's buried. And I say that as long as the data is being reported in textual information, that's a mishmash of other textual information, associated with, vomiting or any type of symptom to any diagnosis that could be buried in textual reports. The way to get it out is through natural language processing, real-time natural language processing. If this data is more reportable now electronically, then we can capture it through these electronic questionnaires that we have and are implementing. And in that sense, then we can make that data more readily available to the clinician inside the clinic, and as well as tailoring the electronic medical record to be able to accommodate those types of data.
Absolutely, thank you. And I know that we are at time. Do we know how we know if the Vice President is ready for us?
John will get a call.
Okay, I was going to say we might get to, I might get to do the third part of the follow-up question, which is to Michaela, which is that are networks like the Orion network ready? Oh, he is speaking. We will stop. Wow. So we will move.
And so I want to thank you.
Thank you, Victor.
Thank you for your incredible work. Thank you for your dedication. And by the way, sometimes I know that my impatience comes through. I sometimes am too passionate about the things I care so deeply about, and nothing I care more about. But I'm more optimistic. I'm more optimistic than any time since we launched the Moonshot, because what I've seen and heard today, the ideas, the collaborations. You just heard from my executive director, Greg Simon. These are a down payment on the effort that is needed to truly make a difference in cancer. And I know this sounds like hyperbole, but the whole world is counting on us. I mean that sincerely. Everywhere I go in the world, and I've been around a long time, as Jim knows, I've traveled over 1,100,000 miles just since being vice president. There is literally not a single world leader that I haven't known or met in the last 38 to 40 years. And as I go around the world today, all parts of the world, I go for other reasons. This is what they raise with me. They know about what you're doing. They know about what we're trying to do. And it is, and they want to collaborate as well. So, in my discussions with the patient groups and industry leaders, scientists, physicians, there was a clear sense of, let's get it done now. There's so much we can get done. Data standards. The first meeting we had, I thought, was extremely, extremely useful with the industry community and others. Is that we can get new data standards, we can do it now. There's better ways to do combination drug therapies. We can do it. Cases. New ways to price drugs based on value so they can be affordable and we still reward innovation. We can do that now. I promise you that we're going to follow every one of the ideas you've raised in these breakout groups, and we're going to try to make them realities as rapidly as we can. Remember, cancer never quits. Cancer doesn't sleep. Cancer never says, well, I can do damage tomorrow. It's now. It's now. So we have to move the ideas that you all have generated and that we've reached a consensus on. We've got to move them to reality, and we got to move it and work on it every single day, in every way we can. We have to invest money, the time, the people, the resources to make the difference in how cancer affects our lives. And it matters. You all know it better than I do. Failure is not an option. When has it ever been in the United States of America that a challenge is put forward and Americans went, well, let me see, I'm not so sure we can do that. I'm not so sure we can invest in that. My God, this is the United States of America. And every day here and around the world, thousands of people are dying. Millions of people are desperately looking for hope. You deal with them every day. They're looking for hope. They don't give up. They hang on. They're like our son with the last days. Dad, I'm not afraid. I'm okay. Keep going. You look at the people you work with, and you can't do anything but walk away with a sense of, my God, the resilience of human beings. My mother used to say, bravery lies in every heart and someday it will be called upon. Unfortunately, it's being called upon every single day for so many people. And some are just looking for another day, another month, another year, just to make it one more birthday. Like I said, make my daughter's wedding. You know, you had a comedian stand up in front of you today, dealing with a hell of a verdict that's been rendered. I asked him how he's doing. He said he's going in for his operation. I don't know his public knowledge, so I won't say the day. I asked him anything I do. He said, yeah, pray for me. And I'm going to be okay. Pray for me. You know, folks, so many of you know so much more about the disease than I do. But you know, we can end cancer as we know it. We need to keep this collaboration going. This summit isn't the end of anything. It's the beginning for some. It's continuation for many of the collaborations that we need to address a host of problems. A host of problems. And every one of these collaborations depend on you in this room, the people in this room, and the people you represent from your disciplines. You know, right here in Washington, we had a lot of people, all of you sitting in front of me, but there are thousands spread all across the country. Serious players like you. Groups of ordinary citizens, but also the leading oncologists, the leading hospitals, the leading researchers in those communities, gathered like we are here today. One of the reasons I so desperately wanted this to occur and succeed as you made it succeed is to reinvigorate the country with the notion that we're in this game, man. We're in it up to our hips, up to our ears. To let people across the nation once again begin to believe that, you know, we can do anything. We're here to work with you. And it's clear I've learned so much from you. We're here to support you. We call for help, and you all answered. You didn't need us to call. You were already doing it. You're already in the game. We basically want to say thank you, encourage you, challenge you to make every day a day closer to the end of cancer as we know it. Thank you for being part of the summit. Thank you for all that you do. Thank you for your dedication. Thank you for your commitment. It really, really, really matters, and you know it. I served years ago as a young 30-year-old senator with a guy who was a great guy. I didn't agree with him much on anything philosophically, but he was a man of great character. Barry Goldwater. Remember that expression? None of you women are old enough to remember, but some of you men will remember, and it's been handed down. If people don't know who said it now. But he said, in your heart, you know I'm right. Well, I think he was wrong about his policies, but the phrase, in your heart, you know, in your heart, you know what I'm saying is true. In your heart, you know. If we collaborate, if we share, if we move, if we unite, we can actually change people's lives in a more profound way than we're able to do any time up to now. So I just want to say, God bless you all for what you do, who you are, and the capacities you bring to this fight. And may God protect our troops. Thank you so, so very much.
Okay, can someone tell me what he said? I missed most of that. So, you know, I did miss most of that, but I do think for those who are interested to stay, we now do have some time, and I think we have till about 4:30, is that right, Ashley? You know, one thing, before we get into a discussion, and I hope that we are able to get some discussion going now, I have two requests. I'm going to ask if Donna and Rachel are both here, if I can have them, they didn't know this was coming, but I'm going to actually ask them if they could come back up to the table here so that maybe we can address some questions if there are any for the group, from the group in the audience here. One other thing I did want to say before we leave is I just want to acknowledge once more the work that Ashley Bright and her team have done in putting this afternoon together, because, you know, it was, I think at times, you know, challenging getting this all together, and she's done a fantastic job of getting everybody here and organizing it. And I just wanted to say thanks to her and everyone else. It's been a really interesting afternoon so far, so thank you, Ashley and team. So, like I said, I'm going to ask Donna and Rachel to step up, and what I would like to do is just picking up on the theme that we introduced earlier on in the day. You know, I think there are opportunities for us to make a contribution, and especially around those access and big data issues that we discussed early on. And there are issues, I think, which are very specific to Utah because of our geography and so on, and some of our previous experiences, which perhaps are messages we can also send back. I'm going to start out by putting them on the spot and asking Donna and Rachel if there are themes that they've picked up from the day and from this afternoon, which they think are important messages to send back. And then what I want to do after I've invited them just to say a few words is open this up and just invite anyone who's here to ask questions that they may have or make any comments on really any aspect of the moonshot, but in particular, messages that you think it's important for us to be able to send back to the White House. So, Donna, any take-homes for you from the panel discussion or the afternoon as a whole?
Yes. Well, I think the main take-home that I have just from the moonshot in general, and in order for us to progress, to make 5 years of progress 10 years of progress in 5 years, I think collaboration is key, and I'm excited to see so many people here from so many different areas. And I know with our panelists, a lot of the work that we do is collaboration with partners in the community, whether it's with community hospitals, whether it's with agencies and organizations that are reaching underserved communities, and so we're always partnering, and I really think the key is we do all have to put, it's difficult when we all have organizations we're with, but we do have to put our egos aside and work for the common good of the patient and what we're trying to achieve together. And I think it's a very exciting time, and if we can keep the momentum that has started, I think we really do have a shot to see this. I've been working for 28 years in the cancer field, and like I said, there has been great progress, but it's not fast enough and it's not broad enough in certain areas. So I do think through collaboration, again, that's key, and that's the theme. And I'm hoping that we hear from some of the people that are here in the audience ideas of how we can partner better with you all. So,
Rachel.
I think that one of the most, that there are two concepts that we heard today that I'd like to link together, and that's value and prevention. The value that we get, both in terms of cost and lives and quality of life, of preventing cancer, preventing a person from developing cancer, preventing a person predisposed to cancer from developing cancer, is incredible. And that work keeps people involved in their families, involved in their communities, and involved in all aspects of their lives that is not treating cancer, but not getting cancer. And that the promise that we have of using the data that we're able to generate both internally from our genetic data, our clinical data, our pedigree data, as well as working with collaboratives like Orion and other areas, brings us to a place where hopefully we're not curing cancer, but we're preventing cancer. And that I think is so exciting, to be able to think about the preservation of people's quality of lives in that way, I think are critical. And obviously, we want to do a better job treating cancer when we have to. But if we can get to the point where we don't have to treat cancer because we're preventing cancer, I think that's truly an amazing opportunity, and hopefully one of the results of this moonshot.
Thanks, Rachel. One of the questions that Vice President Biden had when he visited us here at Huntsman Cancer Institute a couple of months back was he was asking for opinions on things that the federal government could do that would make a difference to us right now or in the near future, in terms of how we meet the needs of our cancer patients and how we meet the needs of our cancer research community and so on. And so, that's one of the things that maybe would be a good way to focus some of our discussions this afternoon. I mean, just to give an example, and I'll just kind of preempt this by telling me that a while ago somebody said I shouldn't even suggest this because it's too political, but there are no controls on me today, so I will. So one example, and something that was raised during Donna's panel, is the fact that increasingly now we know about how powerful remote cancer care and cancer prevention can be. Marjan told us about genetic counseling, telephonic genetic counseling, which is as effective as in-person genetic counseling. There are many, many other examples of health-related apps and so on, of telemedicine, and all of those aspects of remote care that for rural and frontier communities, could be incredibly powerful in improving our reach and improving our impact. But one of the challenges that we face is that very frequently what we're then trying to do is we're trying to practice our various disciplines across state lines. And that is problematic, certainly from a physician perspective, because of requiring licensure in all those states in which you do this. And so I'm unashamedly looking at Kim here in a way, because I think, this is one message, I think. This is something which, if there were a way to address it in some way, would be an incredibly powerful tool for us as we look at how in very, very widely spread communities, something that could be done that would actually potentially make a real difference to anyone affected by cancer, whether it be at the prevention phase or during their treatment. So that's one example. I'm sure there are many, many more. And I'm now looking for the hands to go up to start coming up with some questions or thoughts about this. Go ahead.
Hi, we have a question from our Facebook audience. Are we going to allot more funding to pediatric cancer research? Young people need innovative treatments.
Okay, I don't know. Do we have anyone from our children's cancer community here? I think, in the absence of anyone here specifically, I think, that's the answer is yes. I mean, I think every aspect of what we do in terms of cancer research needs more funding. I think many people in the room here will know that certainly here, at the Institute and in the state, we've made a very significant new investment in research into pediatric cancer with the building that's going up right now on the south end of this building. And I think clearly, the understanding of pediatric cancer has implications, like almost everything that we do. Research in one area of cancer usually pays off into other areas as well. It is, to some extent, a particular priority here because of our very young population. I think, speaking personally, the other area where we have a truly underserved population, where we should be encouraging more research, and I think it's something, again, that through the Moonshot we should be thinking very hard about, is our adolescent and young adult communities, where we know outcomes in those populations are not as good, either as children or as older adults. And so, you know, that group, for all kinds of reasons, is underserved, and I think another message that we could send back would be about exploring what we can do to improve the service that we give those folks. Ben.
I appreciated Dr. Hess's remarks about prevention being a key initiative here. We live in a system that does not financially support preventative programs to a large degree. Hospitals, clinics, physicians get paid to take care of people who are very sick, and there's simply not a lot of money or funding for prevention and early detection programs. I'm just curious what you think about that.
I'm an optimist, and as anyone who knows me knows that I can find the lemonade in almost anything. I think that there are a lot of things that are scary about prospective payment models and accountable care organizations and all of those new fangled, whatever we call them these days. I think that one of the encouraging things is that if there truly is a population that you're caring for, and if that population really is the community in which you live, then the motivation to spend healthcare dollars as well on not only treating illness, but preventing illness through nutrition counseling, physical activity, increased cancer screening, increased screening in general, improved walkability in communities, reducing carcinogens in our environment, et cetera, becomes part of what we do in healthcare. And we start to move away from a medical care environment and more towards a healthcare environment. I don't know if that's going to happen. I think we wait and see. We encourage it to happen. We work with the people who pull purse strings to try and make it happen, but that's my hopeful upside of payment reform as we go that direction. I think that in addition to the medical community and how we deliver care to people, the research is a lot more exciting in curing disease than the research is in preventing disease. And there's a lot of work to be done to make sure that behavioral interventions and other things like that are also attended to as we're working on our outcomes, including our cancer outcomes, to make sure that we are fully supporting the range of things that we can do to improve people's quality of life and keep them healthy.
You had a question?
Yeah, so my question's prevention/genetic testing. My dad has the breast cancer gene, and there's 7 kids, and some of us were tested here at Huntsman, and then some of us, my one sister was tested at Cancer Treatment Centers of America. And the information that was told to us as the final, suggestions was completely different. And it was, it sounds simple, but it was one said remove fallopian tubes, one said it's not necessary. So I guess my question is, once this collaboration becomes, better understood, who has the final say of what the best information is?
I'm going to invite Marjan to answer that. Is that okay, Marjan? Yeah.
Oh, thanks. So right now, we are an NCI designated comprehensive cancer center, so we follow, and I'm sorry, who asked the question? Thank you. I'm just looking out in the audience. So we follow NCCN designated recommendations when we give those recommendations. I will let you know that fallopian tube Yes, that's part of the surgical removal for BRCA genes as well, but we can have another conversation. I agree with you. There needs to be some sort of standardized practice. So with Huntsman Cancer Institute being a member of NCCN, it allows us, with many other academic centers based on research, knowing what those recommendations are. I think a lot of centers, unfortunately, across the country, especially those who are practicing more maybe rural frontier areas, don't necessarily have all those resources, don't have access to that data. And so, yes, the goal is to standardize care across the whole country, and we're working towards that in small steps right now.
Any other questions out there? Yeah, another one.
We have another question from our Facebook audience. Could the federal government help cancer patients and their providers by establishing standardized EHR protocols?
Wow.
You want me to say something?
Yeah, why don't you say something about the
Wow,
comment?
yeah, it's fascinating that that we have so much electronic data, and the language that the data are in are all different. I was recently in London and took a picture of the Rosetta Stone, kind of half jokingly, to include it in all of our EHR talks from now on. I think that there's not only the issue of common language within or between EHRs, but also sometimes common language within a single EHR. And there is huge work on standards and interoperability, and a lot of that work, for those of you that don't know, happens in Utah. There is the biomedical informatics department here serves on almost every major interoperability initiative to try and move data more seamlessly. And so I absolutely agree that not only do we need our electronic health records to communicate better, but I would take it a step further and say we need our electronic health records to communicate clinically. That if we are seeing patients who are seen in one area, we should be able to, with their permission and consent, get those data so that we can continue treatment wherever they are. And that's aspirational. The federal government has been supporting those efforts through the Office of the National Coordinator, and I would completely agree that that work should continue robustly and is key really to all of our treatment efforts, not only in cancer, but particularly in cancer, especially as we have more survivors who move from one region of the country to another to continue their lives.
Thanks, Rachel. Another question, Sarah.
Thank you. As you mentioned, to serve more the underserved populations, I want to think that in that category fits the Latino population and other minorities. My question is there going to be more opening to serve this population in terms of prevention, in terms of more access to clinical trials? Most of those underserved populations are uninsured as well. So what are our hopes with the Huntsman Cancer Institute to serve more of these individuals?
Okay. Well, I can speak on we definitely are looking more for doing prevention with underserved communities, Hispanic, Latino as well. And I know their efforts to educate with part of what the work that Jennifer is doing with the Community Health Education Grant is as we go into the different communities and we find out what their needs are, tailoring programs for those communities. And we do have the data that shows us, who's not getting screened for cancer, as well as who's being diagnosed at later stages with the disease. So in each of those health districts that we're going to, we're looking at that. And so some of them are rural underserved, so that would be the community. But within rural underserved, there may be ethnic and other cultural groups that we'd be looking at to serve there. And I don't know if, Jessica, if you want to comment on the clinical trials?
So from the clinical trials perspective, we do track and try to always reach out, working very closely with Donna's group to make sure that the other underserved populations in our communities are aware of the clinical trial opportunities that are here or maybe closer to their home. We readily have access to hospital translation services for those patients if they do come to this facility, and also ensure that all of our clinical trial materials are translated into their native language appropriately so that they have a clear understanding of the clinical trial components and the special unique features that they might have to be part of as they enroll and participate in those trials. So we definitely want to keep that open and make sure that they know those opportunities are available for them from the research perspective.
And yeah, there's a question at the back.
So my question has to do with data sharing. So in this summit, we talk a lot about how we share the comprehensive data with other areas of the country, with other institutions. But what about in our own institution? Because doctors and PI, they are very protective of their own data. For example, I work with the Cancer Clinical Research Database, and I work with many of others in our group, but we input our own data in without being able to see what the other groups are putting in. So a lot of time we could be triple or quadruple putting in the same information, but not being able to see that. So what steps can we take so that data sharing in our own institution is more of a possibility?
Wow, that's a great question. I'd take a shot at that, but I'm going to ask Samir, do you have anything that you would want to comment on that?
Sure, actually. Well, the systems that we have built here internally are guided